Distinguished program directors, moderators, colleagues, ladies and gentlemen. Thoracic outlet syndrome is highly underdiagnosed. It affects up to 8% of the population. It's a disease of young females, and it can present with a number of varying symptoms, which sometimes don't make a lot of sense. It really can be described as an enigma. It's mysterious, puzzling, difficult to understand. And we've been thinking about this the same way for the last 60 years. Some of that comes from the fact that our present discussion and classification of this disease goes back to 1956 and a paper by a physical therapist from Mayo Clinic, Pete, who tried to put together in a cohesive manner the group of patients who presented with upper extremity symptoms. Needless to say, this concept of neurogenic, venous, arterial, which came about from Pete's paper, has just caused more confusion because the majority of patients have neurologic symptoms, yet 95% of that 95% are called disputed or have been called disputed because there's no objective finding. And then surgery is used as a diagnostic modality in these patients, or the patients are denied surgery and they go get physical therapy, et cetera. It's interesting that when you talk about TOS, everybody gets attracted to the 5% who have cervical rib disease and bands. That is the easy group, that's the low-hanging fruit, and that's not what we really should be interested in. Suffices to say that in the 6 decades since Pete's publication, the only consistent aspect of TOS has been there's confusion among medical practitioners, difficulty in making diagnosis, and poor surgical results. I want you to leave your comfort zone today, and let's go where magic happens, where we think outside the box. This is what we've been doing for the past 15 years with this disease, which has resulted in multiple publications that you can read on your own. But let's talk about some new ideas about this disease. The most important question is, who should undergo first rib resection? Well, let's start with Paget-Schroeder patients. When we looked at the first ribs resected by our group in Paget patients, we found that retrospectively that there is an abnormality at the costosternal junction, and there's a tubercle where there should be a flat or a divot in the area of the bone. We published this as a pathogenesis possibly of Paget-Schroeder, where the vein is compressed by an extrinsically abnormal portion of the first rib. You can see this in the 3D reconstructions, and you can see it in a venogram here in this patient, and also you can see it's bilateral, which gives it more credibility as a congenital problem. When the patient elevates their arm, the bone compresses the vein and occludes the vessel. And when I was in Arizona, we came up with a protocol for MRV, where you can see the compression of the subclavian and intima junction. And if you see this and you intervene and remove the first rib, then obviously you are going to help these patients. This is a resected specimen with the tubercle. And when you look at the data, this is 83 patients reported in 2019. After you open up the vein and remove that extrinsic compression, you can see that at 24-month follow-up, 100% of the patients have a patent subclavian vein and a normal upper extremity. This is pleasing both to the surgeon and the patient because you actually went after an objective finding. What about these neurogenic patients? Probably a better term is neurologic patients, or they have symptoms that are neurologic. The 95% that are disputed probably represent many subgroups, but in these patients, we also saw that in a subgroup of these patients who have no other objective finding, there is that tubercle and abnormality at the costosternal junction. And the hypothesis has been that venous ischemia occurs, congestion of the upper extremity nerves then leads to the neurologic symptoms that are all over the place, as opposed to nerve compression, because the nerve conduction studies in these patients are negative. And we know this condition well. Everybody in this audience knows what it feels like to cross their legs and the leg falls asleep, and you have a variety of neurologic things that occur. That's all from compression of the popliteal vein, not compression of a nerve in your leg. And it's the same thing that presently it's thought that a subgroup of patients with disputed neurogenic TOS have upper extremity venous claudication, similar to that lower extremity symptoms that everybody knows well. And in those patients, if you get an MRA, you will see compression extrinsically. And if you look at this is 79 patients that were reported recently. You can see the MRA shows compression of the vein. This is, by the way, bilateral, one side worse than the other. And when you remove the offending portion, as it's called, the vein pops open, the drainage of the upper extremity improves. And as you can see in this data, the quick dash, which looks at the stability of the arm, preoperatively 52, the top number is 55. 6 months, it's down to 3.5, a significant difference. And if you look at their symptoms, 91% get relief immediately post-op, but they continue getting better, just like your leg falling asleep and then you uncross it. And then at 6 months, there's 100% relief. This is pleasing both to the patient and the surgeon. So who should undergo first rib resection? Only patients with an objective finding of extrinsic compression of the vein on MRA or other objective findings, period. Here it is in this group of patients, you can see compression. So what's the advantage of the robot? Well, if in these patients, the disease is at the costosternal junction, and you need to disarticulate the joint and remove that medial portion of the first rib. This joint was actually what was called by Dr. Urchel as the costoclavicular ligament, which he felt was significant in making these patients better. So to do that, you need to be inside the chest. And so for this subgroup of patients, Paget-Schroeder and then these group of disputed ones, the robotic approach is the only way you can do the disarticulation, at least easily. Here is the procedure. 3 trocars are put in, camera, right arm, left arm, and then a 4th trocar for the retractor to push the lung down. And then at the end, we put a chest tube there. The view of the apex of the chest in these patients shows you that the first rib is abnormal. This is very much curved in like a comma, which you see in all these patients, going with the congenital abnormality. And we're going to operate here. There's the SVC, inanimate vein. And it's important to note that we have never had any issues with the phrenic nerve, which is something that comes up all the time, because there's a lot of tissue between the phrenic nerve in this location and the first rib. So unless you are lost in the anatomy, you will not have issues with the phrenic nerve. Looking at a video of this operation, the first, once the robot is put in, it's a 30-degree up-viewing camera, hook in the right hand, grasper in the left. You take all of that pleura off. You'll take all the tissue off the bone, as orthopedic guys would call it, decorticate that first rib so that you're really looking at only the bone, all the periosteum is gone, and you need to see the edges of the bone, both in both ends, inferior and superior. You identify the costosternal joint by the cartilage that you can see coming up in smoke like that. And it is important that the disarticulation is occurring at the joint, because otherwise you'll not be able to do this. In my experience, when we used to do this operation, otherwise you would divide the bone before the joint. Next, we go with an endoscopic camera for the division of the rib. We use a endoscopic instrument that's an endoscopic kerosene. This allows you to push against the subclavian artery. The area that's the thinnest is where the bone is under the artery. In my experience, trying to get around the bone and pass a giggly saw or other powered saws is dangerous. This allows you to protect the vessel as you divide the bone. So this is what I like. And as you divide it, all of a sudden the artery starts to beat because both the vessels are under compression. Once you have divided it and made it into a trap door, then you will replace the camera with a 30-degree down viewing. 2 hook cauteries are used. on the intuitive machine, you have to set up a second cautery. It will only allow one hook to be used. So then the surgeon can use either left or right hand. And then the other hook pulls down on the bone. You see, this is the area of disease right at this joint. This is what's going to be compressing the subclavian vessel as it meets the innominate vein. And again, in the past, we would divide it right before the joint and probably leave disease behind. In fact, we have a series of patients who have had what we would normally have called recurrent TOS. This was really persistent TOS, where this portion was not removed, and removing of this portion made their symptoms go away. So it's key to disarticulate the joint, stay right on the bone, protect the vein. You're going to see the vein, and you're going to take a deep breath when you see it, because it's really close. It's right here. And it's important to note that you see how this hump is what's occluding this vein. And you stay right on the bone. This is a 30-degree down viewing camera, and the cautery set is 30. So what you're doing in a very controlled fashion, peeling this bone off of this vein. You switch to a grasper in the left hand at the end, and you pull the bone towards you so that you're not taking the cautery too close to the vein. You see, we don't even see the phrenic in any of this. And then once it's gone, the vein starts to beat and it is decompressed. The specifics of the operation, the studies that have been done, and the new thinking about TOS can be seen in a chapter in a textbook of robotic surgery that just came out. This is not a cheap plug for the textbook, but it provides a lot more information than I can in a few minutes. I appreciate the opportunity of talking to you about this, and look forward to answering your questions. Thank you very much.